Also this weekend, the National Coronavirus Command Council meeting again amid fears there could be a third wave of the disease. We've still only vaccinated around 220,000 health workers against COVID-19. That leads to the question, just ahead of Easter, where are our vaccines? Why do the starting dates for the next phases of the vaccine rollout keep being delayed? Well, joining us, Professor Shabir Mahdi is a vaccinologist, Professor of Vaccinology at WITS. Fatima Hassan's the founder and head of the Health Justice Initiative. We also have Dr. Helena Marie van der Westhuizen. She's a tuberculosis researcher, but an expert on the impact of face masks. And Sibongiseni de la Glazo is a spokesperson for the nursing union DENOSA. Professor Mahdi, if I may start with you, good afternoon to you. I mean, we seem to be falling, frankly, further and further behind in vaccinating people, possibilities of a third wave coming through. Where do you think our vaccination rollout may have gone wrong?
So good afternoon, Stephen. And I think we got the dubious honor of being amongst 44 countries that are yet to start the COVID-19 vaccine rollout program. In fact, we haven't started the general rollout program. The vaccine that is currently being offered to healthcare workers is being done as part of an implementation study. Where have we gone wrong? I think there's been a series of miscalculations, and most recently us deciding to export 1 million doses of vaccine, which otherwise probably could have benefited high-risk individuals and protect them from severe disease when the next resurgence is upon us. Initially, South Africa was highly dependent on a COVAX facility, and certainly from a social solidarity perspective, it made perfect sense to join the COVAX facility. But at the same time, we always knew that the COVAX facility was only offering countries for enough vaccine to vaccinate 20% of the population. And at that stage, we should already have been thinking about entering into bilateral agreements, just like every other country, many middle-income countries that have been able to adopt vaccines at an early stage that entered into. And that shouldn't have occurred in the beginning of this year, as is the case, but rather should have started around about August, September of last year. In addition to which, it seems that we've been somewhat stubborn. Right at the start of the pandemic, government was insistent that they take the advice from the World Health Organization. When the World Health Organization in the middle of February recommended that even in countries where the B1351 variant circulates, those countries should still use the AstraZeneca vaccine, government decided not to take that advice. Instead, it went on to go and procure 20 million doses of the Pfizer vaccine, which is much more expensive, but which we got absolutely no evidence whether it would perform any better than the AstraZeneca vaccine against mild to moderate infection. So it's just been a series of miscalculations, poor planning, and unfortunately, even at this late stage, I don't believe that even if we were to get millions of doses of vaccine tomorrow, that is going to have any meaningful impact, because the reality is that even when it comes to the deployment of these vaccines, we're going to come short still.
Fatima Hassan, I mean, that's a series of strong views from Professor Mahdi that we've fallen behind, that we've made miscalculations. Do you agree? I mean, there's also a role that, if I can put it like this, the rich world has played in this too.
Thanks, and thanks for having me on the panel. So I definitely agree. I think it's a combination of, severe miscalculations on the part of government, including the Ministerial Advisory Committee. I mean, we've been struggling to even get the vaccine advisories up on the website, which the minister had promised. So we haven't seen the details of the national vaccine strategy, the timelines, how the prioritization groups will work. But having said that, there is an issue around global supplies. There is a severe shortage and a severe scarcity. The notion of a people's vaccine is not necessarily materializing. The vaccine is not going to where people really need it. Many of these companies are refusing to share technology, refusing to share the vaccine know-how, are defending their intellectual property claims, against all basic evidence and against all costs, opposing the TRIPS waiver. And as a result, there's just not sufficient capacity at the moment to ramp up urgently manufacturing and to scale up supplies. So the situation that we have is, even though COVAX, for example, said it will supply certain countries with, X number of vaccines from different manufacturers, it's coming in a drip feed form. Even the deal that South Africa has signed with Pfizer and with Johnson & Johnson, if you look at the forecast, it's going to be a drip feed every month for the next year at least. So the project of global population immunity, our own country's immunity, is at great risk. this because of, I think, two reasons. One, Professor Mahdi has explained quite eloquently, and we support that. We don't think that government is actually acting with the necessary urgency and also the necessary transparency. But secondly, it's in large part due to the conduct of pharmaceutical companies. And I mean, we can talk later about how these non-disclosure agreements and the request for indemnity is actually affecting many countries' ability in the global south to access urgent and sufficient supplies of vaccines. And just the last point, Stephen, almost every single company that has emergency use authorization for their vaccines in other parts of the world or has obtained approval here in South Africa, and as you know, there's only 2 that got Section 21 approvals, all of them are behind their production targets. So it doesn't look that there's going to be sufficient supplies of vaccines. It just doesn't look like it's feasible at all, pushing out the project of immunity.
So if we then are falling behind in our vaccine rollout, if people are not being vaccinated, the people who are going to bear the consequences the most, apart from people with comorbidities, are going to be people in the healthcare profession. I'm talking particularly about nurses, about doctors, about people working in hospitals. Sibongiseni de la Glazo, I'm talking about your members. You represent the nursing union, DENOSA. It's you and your members who are going to bear the brunt of what seem to be mistakes by government, by the health department, perhaps even by other organizations.
Well, indeed, Stephen. Good afternoon, and good afternoon to the colleagues. Well, the vaccine rollout was really our hope that the burden on the shoulders of healthcare workers was going to be somewhat lifted off their shoulders. It is quite disappointing. Of course, we are around 220,000 of those who've been vaccinated. That's a very low number, and would have hoped that by now at least quite a sizable number of them. Well, are we relaxing because we are experiencing low active cases? I don't think we should be relaxing simply because of that. We can't be upping our game only when we are faced with a crisis. The third wave we are being warned, it's imminent. And healthcare workers, we didn't think that they would be able to manage the second wave. It was quite amazing that they did. And they are out of energy as we speak, Stephen. And fortunately, the uptake of the vaccine, from their side is quite up, something which we're very worried about initially. This now they are convinced that it is the right way to do. And unfortunately, we are hitting this brick. And go to Bara Hospital. Long queues of healthcare workers who are queuing to be vaccinated. So the slow pace is a bit disappointing, and our fear is that this may demoralize healthcare workers from having further confidence on this, and that is spelling disaster for us because we've lost healthcare workers. PPE has not proven to be quite sufficient in protecting them, and we're faced with a third wave. What are we going to do? I think upping the game from the side of government and also be transparent so that we could also be able to communicate if there are any nodes that are preventing, the fast-paced movement of the rollout, so that we can communicate that with our members.
So, Sibongiseni, is government just not moving quickly enough? I mean, I'm sort of astonished that this is not, the president, the deputy president, the health minister talking about vaccines every day. Instead, you sort of have to wait for the deputy president to appear in public before we can ask him.
Well, indeed, and I think that's the disappointing part. Well, perhaps, as I mentioned, perhaps we're relaxing because we are thinking that we are winning this battle against COVID. But I think we should have learned a lesson from the second wave, because when the second wave came about, it hit us unaware. And I'm very afraid because in terms of preparedness, the resources-wise, I don't think we'd have more money to be prepared, buying PPE. That is our most concern. So hence I mentioned that the vaccine itself was the last hope for healthcare workers. And we are still talking of the first phase, which is still far from over. And our most, we're quite hopeful that at least the second phase, where you've got the elders and the people with comorbidities, because those are the patients that are likely to be admitted to our facilities, that healthcare workers will have to care for, but we are very far from reaching them, and that is a serious concern. It can't be that healthcare workers are the focus. Yes, it's good that we are starting with them because they are on the front line, but those who will be coming to facilities are the elders, because it's been proven that once they get infected, they quickly develop a severity and would need admission. That's hard work for healthcare workers. That's work overload, and we're not talking about staff, in augmentation in our facilities. What if perhaps even the slow pace is because of that?
We've got a lot more to talk about. We'll continue this conversation with our guests in a moment. Where are our vaccines? Conversation, where are our vaccines? With our four panelists, Professor Shiba Ahmadi, you know him, he's the Professor of Vaccinology at Wits. Fatima Hassan's the founder and head of the Health Justice Initiative. Dr. Helena Marie van der Westhuizen's a TB researcher and expert on the medical impact of masks. And Simbokiseni de la Glazel, the spokesperson of the nursing union, DENOSA. If I can ask you, Dr. van der Westhuizen, you've been looking at the impact of masks, PPEs. We've been talking about PPEs for a year, and I am still amazed at how quickly we actually got so used to seeing people wearing PPEs, to the point now, if you see a movie or a TV production filmed before the pandemic, you're shocked to see people who are not wearing masks.
Yes, Stephen, a really great observation, and thank you for having me on the show. I think it has been remarkable, and I think we've also made incredible progress in understanding how COVID spreads. So at the beginning of the pandemic, we placed a lot of emphasis on cleaning of surfaces, maybe cleaning your groceries when you come back from the shop, and deep cleaning facilities. But as our understanding has evolved, we realized that ventilation is another critical component of preventing COVID from spreading, and we should rather spend energy improving ventilation in indoor spaces, and we should move gatherings outdoors. And then, as you mentioned, masks have become a really important tool, both in preventing us from making others ill, so that's what we refer to as source control, and they also have a measure of protecting the person wearing them. And so I think in the past month, there really has been a conscious shift to asking, is it possible to make the masks that we wear also protect the wearer and not just emphasize the impact of source control? So if you might be ill with COVID and not know it and be spreading it to others, that is what we refer to as source control. And initially in the pandemic, that's what we focused on most. But I think it is important to ask, are we able to improve our masks to also provide some degree of protection for the wearer? And here I'm specifically referring to members of the public. I know that healthcare workers and their PPE standards, it's a separate discussion. So a quick couple of thoughts to start answering that question. It boils down to two components, fit and filtration. And so fit refers to how well your cloth mask fits around your face. Are there any leaks? Is it covering both your nose and your mouth? And here the biggest culprit is masks with valves. And so they completely defeat the purpose. I strongly encourage anybody not to wear a mask with valve. And there has been government guidelines since October last year discouraging or recommending against the use of masks with valves. And why that is so is instead of the mask then helping to capture potential infectious respiratory droplets when you're speaking, when you're breathing out, all of that goes through the valve sort of as an infectious jet of air that can make other people around you ill. So that's the first starting point. But when we're looking at fit and whether it's possible to improve the fit of your cloth mask, there are a couple of tricks that we've discovered over the past year to be working quite well. So the first one is to see if you can have a mask that has a nose clip. So for people who wear glasses like me, that also helps them from fogging up. And the second one is, and this is based on laboratory research by Professor Lindsay Ma, is that if your mask is tied behind at the back of your head instead of having ear loops, that often has a much better fit. But then there's another really simple solution, and I can show you. So if you have a mask that fits behind your ears, simply adding a small knot at that, that's a new recommendation by the Center for Disease Control of another way that you can make your mask fit better. The second big topic is looking at filtration. And so that's really paying attention to the number of layers that your mask is made of. And there, the World Health Organization, the CDC South Africa's local guidelines, all of them agree that we should be looking for masks, cloth masks that have 3 layers, and if possible, that middle layer should be made of a filter material, and there an example is polypropylene. The CDC again have got a nice tip. So if you've got a mask and you're not sure whether it's got the adequate number of layers, if you hold it up against the light and it adequately blocks out the light, you know that is some indication to show that it is effective at also blocking some respiratory droplets. So those are a couple of tips. I think the good news about masks, and my panelists here, the other panelists are experts on vaccines, the great news about masks is irrespective of their variant, and even not just for COVID, but also for TB and for flu, we know that masks remain a valuable preventative tool. And as we are waiting for a larger rollout of vaccines in our country, they are one of the tools that we really should be embracing.
It's an important point, that. I mean, we haven't had the sort of flu epidemic that we normally get at this, over the winter period. We didn't have one last year, and surely masks played a big role. Professor Mahdi, if I may, what do we do now as government? You've suggested that we've made several miscalculations, or that government's made several miscalculations. What do you think we need to do right now? And obviously, we need to get as many vaccine doses into the arms of people as possible.
Yeah, so the first thing we need to do is to reset our goal. Because of the first generation COVID-19 vaccines and their partial effectiveness against mild and moderate infection, and this probably applies for all of the COVID-19 vaccines, the aspiration of herd immunity is something that has passed us by. And there's no country in the world probably that's going to get to herd immunity in the classical sense of the meaning of that word. What we need to look at is a pathway to return to a relative normal lifestyle. And to be able to achieve that in South Africa, the most pragmatic manner in which it can be done is not to target vaccinating 40 million people, because the majority of those individuals will derive very little benefit from this first generation of COVID-19 vaccines. We need to become much more targeted. And what we need to focus on is ensuring that we can vaccinate the high-risk individuals as quickly as possible. The high-risk individuals being those above the age of 65, people with hypertension, diabetes, obesity. All of those risk groups still make up close on to 17 million people in South Africa, so it's still not a small task. And that is what we need to invest our energies on. And then we really need to figure out how we're going to get these vaccines. When we talk about vaccinating in February of next year, let us be clear. By that time, probably 70 to 80% of South Africans would have been infected with the virus. Right now, we're looking at anything between 40 to 60% of South Africans already having been infected. And that past infection probably confers a reasonable amount of immunity against severe disease from COVID-19, even with a B.1.351 variant. So if we're seriously wanting to protect South Africans, we're needing to get these vaccines in as quickly as possible. And like I said, it's not about vaccinating 40 million people, which is, for me, a meaningless target in a context of the types of vaccines that we've currently got available. It's about focusing on those 17 million that still remain at risk of developing severe disease and dying of COVID.
Fatima Hassan, would you go along with that? I mean, I realize these are very complicated conversations. We have to listen to the scientists, but they're also conversations around who is more vulnerable, but they're also conversations around sometimes who is seen as crucial in our society. If you want to finish the school year, maybe you look at teachers. People who are more at risk might be cashiers in supermarkets, though. Fatima, would you agree with Professor Mahdi what we need to do next?
Yeah, so I think it goes back to the issue of equity in allocation and the prioritization. And certainly many civil society groups have been saying that you can't jump to the front of a queue just because, for example, you have money or you have medical insurance. The prioritization has to be based on certain factors, including age, including comorbidities. And that certainly aligns with what the WHO SAGE principles also recommend. But I think, Stephen, there's a bigger global issue. There's two things that are currently happening in the world. The first is that 6 billion vaccine dosages have already been bought up. So I'm not sure where we're actually getting these supplies from, through pre-orders. And on top of that, a number of regional blocs, and now India also has decided on export bans. So the ability to be able to access 40 million of a different basket or set of vaccines is going to be even increasingly difficult, not just for South Africa, but also for the rest of Africa. We've been promised a lot of things, 20 million of this, 9 million of that, 15 million of that. But, when push comes to shove, we haven't even received the promises made by COVAX. It's already towards the end of March. We were told we're going to get 2.9 million of AstraZeneca's vaccine, 197,000 of Pfizer's vaccine. I mean, I haven't seen any reports of those vaccines being delivered. So the issue around how do you deal with the global context locally, and I think there's two issues here that as the media and civil society and as public health professionals we have to focus on is who's making these decisions about the vaccine selection for South Africa, given that there's only 2 Section 21 approvals. We know that Sputnik and Sinovac have now submitted their dossiers. So the process for selecting the vaccines for South Africa based on the scarcity and the lack of, global sufficient number of supplies is a big issue. And the second is who's making the decisions? Where is the professional advice and opinion? Where is the scientific consensus, the bringing in together of all different voices, including workers, around the allocation, because the contestation around the phase 2 prioritization groups is going to be so significant. Already we're seeing people suggesting groups that wouldn't normally qualify under the WHO classifications. And then finally, the global point around how do we scale up supplies so that we're not having this conversation in another year's time. Really has to be, measures to scale up production, and that has to be the sharing of the knowledge. The hoarding of the knowledge has to stop. There has to be more voluntary tech transfer. And if necessary, our government has to stop acting like it's so powerless. It actually has to compel the transfer of technology, because otherwise we're just not going to achieve any kind of form of vaccine equity in the next 3 to 4 years.
It is the conversation, frankly, of the moment, of the last year and possibly of the next year. Conversation around COVID-19 vaccines. We'll continue in a moment. Stay with us. Well, let's continue with our conversation around vaccines and, of course, bring you up to speed with what is happening around the country at the moment in your headlines. 4 police officers accused of murdering Mthokozisi Lutumba have been granted bail. The magistrate saying they fulfill all of the conditions to receive bail. The Police Minister, Becky Cele, says Norma Ngoma has the right to sue the Hawks for unlawful arrest if she chooses to do so. A charge of criminal damage was withdrawn against her. And no end to Advocate Dali Mpofu's shut-up moment. The General Counsel of the Bar confirms a complaint has been laid against his conduct. Welcome back. Continuing our conversation around vaccines, where are they? Professor Shibia Mahdi, of course, the vaccinologist at Wits University, Fatima Hassan, the founder of the Health Justice Initiative. We also have Dr. Helena Marie van der Westhuizen, a TB researcher and an expert on masks, and Sibongiseni de la Glazo is the spokesperson for the nursing union, DENOSA. Fatima Hassan, I mean, there's a big conversation to have around our government. You seem to be preparing some sort of action against our governments. What are you demanding from them?
So I think the first is we're demanding a greater level of transparency and sharing of information. But I think what we're quite concerned about as civil society is that we've been attempting to correspond with government for some time, in fact for months. And we're not seeing any level of meaningful engagement with civil society in terms of sharing information. So we are quite concerned at this stage, towards the end of March 2021, that we actually don't really have a vaccine strategy, nor do we have timelines, nor do we have enforceable commitments that we can hold our government as well as the vaccine manufacturers to. So we know bits and pieces of information through court papers because there were groups that brought legal action against our government. So really at this point we are speaking to our league and how we can also make our government to be more accountable in terms of its obligations in line with our constitution.
So Sibongiseni de la Glazo, again, your members are the ones who are most on the front lines here. You represent nurses. Would you be tempted to join this action? Does government need to be more transparent with what it's doing?
Well, anything that promotes transparency is in the interest of our society. I think government dropped the ball. I think if you remember the AstraZeneca, the rollout plan there, when we had to roll out the AstraZeneca, was somewhat quite convincing. I think it sort of derailed everything when we had to talk of J&J. With the small number that is coming into the country, that will promote transparency, because we wouldn't like our government to be relaxed simply because the war is not visible as yet, because we've been taught by the second wave that we can't relax, So definitely, I think whatever that is going to assist the society and is in the best interest of serving the society, let that be done.
Professor Mahdi, I mean, there's a lot of science that is still being done. And, of course, we've seen what can happen when you get a new variant. And the variant that's currently dominant in this country, we know what's happened with AstraZeneca. We've heard your strong views on that. And I think there's still going to be fallout from that in some ways. How worried are you, this is a strange question, that the science could change? What I'm really asking, Professor Mahdi, is how worried are you that we could have a new variant that actually renders the immunity that people would have received during the first and second wave of the virus and null, that in other words a new variant could come that none of us are protected from?
Yeah, that remains a very real possibility, and it's exactly what we experienced with the second wave. where the immunity that was induced by infection with ancestry virus was only partially effective in protecting against mild to moderate infection. But that being said, even our experience in South Africa is strongly suggestive that past infection with ancestry virus probably still reduce severe disease due to the new variant. And the same thing would apply to all of the vaccines. The vaccines are very likely to become less effective as the virus continues evolving, because these vaccines have largely been targeted to the ancestry virus. But it will become less effective against mild and moderate infection. The type of immunity that we require to protect against severe disease, which the vaccine induces, is probably different from what we require to protect against mild infections. So past infection, as well as the first generation of COVID-19 vaccines, are highly likely to protect against severe disease. So yes, the virus is going to continue evolving. We're probably going to see further mutations. But for me, the focus right now, it's not about people getting infected with the virus. It's about trying to minimize the risk of people being hospitalized and dying. I think we just need to come to accept that the virus is going to be with us for years to come, and definitely during the course of our lifetimes. Getting to the so-called magic threshold of herd immunity is not going to materialize. And the sooner that we get away from the notion of herd immunity, the more informed we can be in terms of our future decision making.
You're asking, I mean, that's quite a thing you're asking, and I have heard you make the suggestion before, almost from the beginning. In fact, you've been saying we have to get used to this virus, because I think most people here and around the world, and certainly most governments, I mean, Joe Biden in the United States is saying, you know, he wants to double his vaccine target because he presumes this country will go back to whatever the United States calls normal after that. You're suggesting that actually everyone around the world, there's no going back to what normal used to be.
No, I'm suggesting we can go back to a normal lifestyle, even with the virus in our midst, provided that we're able to protect those individuals that are at high risk of being hospitalized and dying. And if we're able to get high enough penetration of vaccine into that group as quickly as possible, in fact, we can pretty much stop wearing the mask, even with the virus still circulating. The focus here is not about protecting people from being infected. That is a good to have. And had we had enough vaccine for the entire world over a short period of time, we might really have been able to eliminate the virus. But that ship has sailed by now. What we really face with now is a virus that has become endemic, will continue circulating, and the focus, like we do each year for seasonal influenza, as an example, is vaccinating individuals that are at high risk of dying from seasonal influenza. And that is where we need to shift, and that's pretty much where we're going to be in the years to come with COVID-19. It's going to be around, it's still going to kill people, but not at extent, and not to the magnitude that it does currently.
Dr. Helena Marie van der Westhuizen, I mean, just the issue around face masks, and I think this is an important point, is that face masks, the technology, the way that we wear them is actually improving. And I like your point about if you hold it up to the light and you can see through it, it's not providing proper protection. I think that's a really useful rule of thumb, if I can use that expression. But it shows you that, unfortunately, a face mask just isn't really as good as a vaccine. Vaccines are still going to be crucially important in all of this.
Even so, I think when we're speaking about our preventative toolkit, it's important not to make it an either-or question. So it's either vaccines or masks or improving ventilation. When we are trying to prevent the spread of a pandemic that has caused a huge amount of suffering, it's not either-or, it's and. And so we should be using masks and testing and tracing and improving our ventilation and supporting people as they go under isolation if they've been diagnosed. So I think that is a bit of a false dichotomy. I also just want to bring tuberculosis back into the mix, because if we look at 2020, TB and COVID led to similar numbers of deaths in South Africa, yet our conversations are dominated by prevention strategies for COVID